Hi, I'm Omar Manejwala. I'm the Chief Medical Officer for DarioHealth, and today I'm very excited to open a dialogue with you about digital therapeutics in the Medicaid space. I think we've seen that while some digital health solutions are showing their ability to drive engagement and value in commercial populations, there is, I think, a perceived bias that Medicaid populations can't successfully engage with these technologies. And at the same time, the companies that are focused on digital health have often been leaving Medicaid populations behind and focusing either on commercial or on employer spaces. And then also we're seeing new data that really challenges the prevailing narrative around the value of digital health in various subpopulations within the broad Medicaid groups. So today, what I'm hearing from you is that you'd like to hear about what have we learned from successful deployments, and in particular, what are some of the key characteristics that digital health solutions really need to have if they're going to deliver value for payers and for the 1 in 5 people in America who are touched by Medicaid plans. And so one question that we'll be attempting to tackle here today is, are we going to be repurposing solutions that are meant for Silicon Valley and for the Silicon Valley connected self, the Peloton users who may live in Mountain View or Burlingame, and try to force them into a Medicaid-like environment? Or are we going to have solutions that are developed specifically with the unique needs of Medicaid subpopulations and the unique opportunities to create value that exist here? And first of all, I think we're really creating a explosive growth in this area with digital health solutions, especially point solutions that are really kind of taking off and gaining wildfire-like traction. We've seen massive venture capital funding in this area, private equity funding in this area, hyper growth. A lot of that was fueled, similar to telehealth with COVID. With the need to very rapidly migrate the site of care to remote. People couldn't go into the doctor's offices. We needed to adapt, so we did. And what we did was we took technology that has been around for 30 years, and we just did more of it, essentially. And that's really what telehealth has been. We'll talk a little bit about the differences between telehealth and digital health in this space. But at the same time that we did that, and we made those video visits and mostly telephone visits possible, it made sense to also look at complete virtual care, especially asynchronous solutions that could really start to address chronic conditions remotely, try to influence the majority of the levers to health which exist outside the doctor's office. A lot of the factors that drive whether I'm going to be healthy or not are happening in the doctor's office, but most of those factors, as I think everyone knows, are really outside the office. And so how do you influence life? How do you influence life, and how do you influence those levers outside the doctor's office? So all the behaviors that if people change them, if people form those habits, it have a very significant impact on clinical outcomes, on quality, on utilization patterns. So it made a lot of sense that commercial health plans and employers really started to look at this as they set their digital strategies. And the general assumption is that most populations are, if they're not digital natives, they're at least digitally comfortable. And so the companies followed and really created a rash of products and solutions that flooded the space, that really overwhelmed the space in many ways. And we're seeing a large number of pilots for sure, and some widespread commercialized solutions as well. So we are seeing some scaled solutions within the plans. We're seeing some things work, and we're seeing some solutions really gain traction. A lot of lessons learned from employer markets, from commercial markets about this. We're seeing that engagement is key, and that consumerized solutions are really appreciated. And what I mean by that is there's a lot of solutions out there that are sold to health plans or sold to employers, but you can't, if you're an individual and want to go try it, you can't just go buy it and try it out yourself. On the other hand, you got solutions out there that do have some consumer DNA, that have been sold direct to consumer and have done, solved the hardest problem first, which is get anybody to do anything consistently and pay for the privilege of doing so. And so you can't really underestimate the value of that direct to consumer experience. And we're seeing, key chronic condition metrics. We're seeing things like HbA1c, estimated HbA1c, pain, validated behavioral health like PHQ-9, real validated kinds of measurement-based care with outcomes that are being impacted by these kinds of solutions, and impacts on condition-specific costs, and even in some cases impacts on the total cost of care, the total paid claims. And so that's been really wonderful for many, many populations. But the question is, what about everybody else? And so, we've seen this movie before. And either because of inherent population challenges related to social determinants of health, access to broadband technology or other kinds of structural factors, we aren't seeing access to value that's truly possible if we were to focus on the core and varied aspects of Medicaid populations and subpopulations. So once again, we have a divide. The technology was supposed to solve that divide, but yet, here we are with solutions being deployed much more often in other spaces and not really uniquely tailored to the needs of these populations. We see health equity challenges. We see access to healthy foods, food deserts. We see language barriers, see cultural barriers, a lot of cultural barriers, educational barriers, reading level related issues. And the tech solutions have not really focused their development around solving those problems. I mean, there are some, but by and large, it's been, let's see what works over here with let's say the haves and the wealthier and the worried well, and let's hope that it can also then scale and apply to these other populations. And those of us who've been operating in the Medicaid space for some time, we know that that movie doesn't end well. The end result ends up being that provider visits, synchronous telehealth visits, that may be possible now. We've got that. But access to the 99.9% of a person's life that's spent outside the doctor's office, that's less influenceable. And so a solution that's designed for, as I said, a Peloton user who may live in Burlingame or Mountain View, that's not going to work for someone who's in Baltimore or rural West Virginia, especially, rurality can play a huge role here, who has a really old Android phone or a really old iPhone that they bought for $30 or with a headphone jack, or some of these older operating systems that don't have access to broadband. They can't access the broadband at home. The way they access the internet may be at the Wendy's or at the Walmart, and that person really needs solutions that are delivered asynchronously, so they can do the work here and connect to the internet there and and have that kind of flexible, configurable kind of journey with cultural sensitivity, with educational level that's matched to the insights that are really personalized to them. And so Medicaid is a missed opportunity then for development in this space. And shortly I'll talk about what to look for specifically when shopping for solutions in this space. But just start with the obvious one. I think the question that you can ask solutions that are pitching to you, that are looking to operate in this space, what portion of your users are from low socioeconomic status? That simple question can really help separate so much as you look at the noise of the marketplace. What are your Spanish-speaking outcomes specifically? How are you supporting users with the oldest phones? The phones that are, $30, $25, the oldest Android phones, the oldest kinds of iPhones that are still out there operating. How do your solutions work for people who don't really have access to broadband at home? How do you work for people with lower reading levels? What are some examples of that? What about the challenges, the unique challenges of pregnancy? How are you handling those kinds of areas? And how are you personalizing within subpopulations within our lines of business? Because I think there's also a tendency outside of Medicaid to view Medicaid as a single persona. And I think we know nothing could be further from the truth. In fact, we've got more disparate kinds of personas within these populations than you could say even commercial or employer that you see over on that side of the shop. So, all these questions are questions that most solutions that are currently being sold into employer and ASO and commercial full risk environments won't be able to answer well. They won't. And there hasn't been too much of a focus on this because there are biases even among the companies themselves that these populations, they won't be able to adopt. It's too much effort. They can't use technology. Which we know that may be true for some, maybe even for many, but it's simply untrue for the majority of the population of these plans who are using technology. They are using technology in various forms. They just aren't using it in the same way that others use it. They aren't necessarily using it to engage health or health plans in that way. I mean, folks generally don't wake up and think, I can't wait to log into my plan portal, right? So it has to be solutions that are really that deliver solutions around areas that are important to people at the time that they're using that. So there are lessons to learn. There are lessons to learn from direct to consumer deployments, which are really built around, solving what's important to people. What is so important that people are actually willing to pay for using it, to pay for it themselves. And what we're seeing in these populations is that they are using phones. They're using older phones, but yes, smartphone adoption growing very rapidly. And we're seeing they use technology, as I said, at different times, in retail environments and out and about or at a friend's house. That's how folks don't necessarily have continuous access. So most of the current digital health solutions are simply not designed for those types of personas. Broadband, I think we all agree here, is a social determinant of health. I think we can agree not everybody has it, but in the meantime, we aren't seeing much development around solutions that make sense for folks who use technology, but use it differently. And as I mentioned, many folks don't really understand that there are many different personas inside this in terms of chronic condition overlap, social and personal determinant of health overlap, and all those overlapping circles or really spheres, because this is definitely a multidimensional look at how these unique personas exist within the population. And they differ from each other pretty dramatically. And so at the same time, though, we've got groups with rising diabetes, very rapidly rising obesity, MSK, musculoskeletal chronic pain, major driver of cost, major determinant of health, behavioral health, which is, obviously endemic. And when I entered the space, 10 or more years ago, I'm a psychiatrist by background, but when I entered, the solutions for the health plan space 10 years ago, we were having to make the case that behavioral health interventions were influencing medical costs. That's not true anymore. I think it's moving away from the redheaded stepchild kind of view, and there's more of a view. The question is how to solve it, but there's more of an understanding or a view that, hey, this is a missed opportunity, and we really need to solve this. It's urgent. I would say that we're in need of solutions in the Medicaid space. We're in urgent need of solutions that are scalable, that are high value, and we need those more than probably any other line of business. The need's so great that we've even seen announcements of Medicaid plans launching solutions, even if they haven't been validated in subpopulations, even if they were solutions that were meant for Silicon Valley rather than downtown Atlanta or rural North Carolina. And so that's how great the need is that folks have been willing to flex away from kind of the core approaches that they would otherwise use for product evaluation. And the need is so urgent because they really need to access scalable value. And there's a certain portion of value that you just can't get through care management. Care management, wonderful. You can't get it through health plan digital assets. You can't get it through telehealth. You have to be able to access this portion of the member's life and really support them in the areas that matter to them. So telehealth has had an explosion, and Medicaid has benefited from this as well, obviously. So why not just grow telehealth even more? Why not just do more telehealth? And again, we did see a huge, enormous explosion for telehealth. Then we saw dialing back some. And now with Delta, we may see more as well. But, let's be honest. Telehealth is not appreciably different than it was 30 years ago, right? For most people who use it. I remember the first time I used telehealth. I think it was 20 or more years ago. What we've basically done in the COVID environment is pave a cow path. We took the way people were doing things and we just hardened it. And without taking advantage of all the incredible capabilities that digital offers. Now, sure, there's much more of it going on than there was before, but at the end of the day, as I mentioned, 99.9% of life is lived outside of that doctor's visit. All those decisions, what time should I go to bed? When should I wake up? How should I shop at the grocery store? How should I socially interact? Should I take this med? What should I do if I have a side effect? All the questions that really determine and drive health occur outside the doctor's visit. And that's a big black box in many ways for telehealth, for doctor's visits. And doctors have known for a long time they're taking on risk, and they'd like to have levers to influence that. And so the ability to reach into the pocket, into the homes of people and support them on these areas is very, very powerful and is really coming into being here. So most of the decisions are made outside the doctor's visit. Almost nobody believes that making physician visits more frequent is going to solve the bulk of the problem. So convenience is very important. We have to make doctor's visits easy. We have to make provider visits easy. We have to encourage that. But I think people see that there's an asymptote there, and there's only so much improvement that can be gotten from that angle. And now the next question is, where is the opportunity to add digital health to drive complete virtual care? Commercial's already moving in that direction. That can be done low cost, if it can be done high value with high engagement and value-based, especially putting fees at risk against clinical outcomes, fees at risk, and evidence that there's actual adoption in Medicaid populations, then I think that's where it makes sense to really start to deploy. So now I want to step back for a moment and maybe zoom out and take a look at what it will really take if we're going to innovate in the Medicaid space to deliver solutions that people will actually use. We've seen the failed pilots of so many vended solutions, the things that looked good on paper, but people didn't end up using them. The solutions that really didn't work well in our specific populations. So if we zoom out, if we fly up to the, not the 30,000 foot, let's fly up to the Kármán line level. I think part of what's missing here is taking a lesson from just innovation in general. How do retail innovations occur? What do we know about innovation? The things that really tend to work and those that tend to fail. I think if you look at Amazon, if you look at Apple, if you look at Walmart, even if you look at Dollar General, which many of our members use, right? If you look at TikTok, if you look at Netflix, it's really been about convenience, simplicity, and a level of personalization that we haven't seen before. It's obsession with the customer, of absolute obsession with what's important to the customer. Everybody, I think, especially in this space, it's easy to roll your eyes back in your head when you hear people say they have a disruptive solution. Everybody likes to say they have a disruptive solution. At the end of the day, the only disruption barometer, the only measure of disruption is engagement. That's it. I recognize that's a controversial statement, but at the end of the day, if you tell me your solution is disruptive, all I want to know is how many people use it, how often do you use it, and how much do they like it? That's it. And after that, then there can be questions about, did it work? Did it help their health? All these other kinds of areas. First, you have to get people to like it, use it, love it. And that's critical. And Amazon figured that out, and TikTok and others, all these solutions that are out there that have virality, that are being used by the people we serve. Those solutions won because they understood the relationship between disruption, customer obsession, and engagement. And by that definition, almost nothing is disruptive. Almost nothing. I encourage, if you don't already roll your eyes, I encourage you to now roll your eyes at anything that says that it's disruptive in that space. And so as you look at and evaluate solutions in the space, I recommend that you ask these solutions that are approaching you. Are they available direct to consumer? What do we know about consumer use of those solutions? How are they rating you in the Apple App Store and the Google Play and Amazon? What do they think about you? Read the reviews. Look at what users are actually saying about the solution. Because in many ways, a lot of the solutions out there are designed to change health plan behavior, not designed to change people's behavior. And at the end of the day, if we want to drive value, we've got to really focus on that. The solution can't delight the customers, then there's little chance of success in B2B to C. And so when we think about the obsession over Medicaid members, what does that look like? The myriad complex Medicaid member personas, the chronic disease overlap personas, the low income personas, where conditions intersect with social determinants of health, with the personal determinants. And what I mean by personal determinants of health are the way we form habits. What's interesting to me? What am I willing to try? What do I detest? As I look at my own habits over time, what worked? What didn't? What did I tend to give up on? What caused me to give up? All those behavioral science drivers of habit, all those personal determinants of health, those vary not only between people, but within people over time. And those overlapping characteristics really define the personas that demand our attention, and that require not just our interest or our focus, but our absolute obsession. We have to obsess over that complexity if we're going to deploy solutions that work. How do they use technology? When do they use technology? And how does their use of technology change over time or over context? Do they use technology differently when they're at a friend's house, or whether they're at home, or whether they're at the Walmart? So what do they prefer? What do they dislike? In general, people hate portals. That's a known phenomenon. And they especially hate patient or member portals. When they use them, if they have to use them, or if we pay them to use them. Not always, of course. I'm not saying that's universal, but that's pretty much often the case. On the other hand, there are direct-to-consumer solutions inside and outside of healthcare that, 1 in 5 of their users are low income. And they're literally paying for the service for the privilege of being able to use it. Folks who can't afford to are paying for it to use it. And that's a very powerful, I think, testament to, okay, is this focusing on what's important to the health plan, or what's important to X, Y, or Z company? Or is this focusing on what's important to me, the person using it? And what can we learn from those kinds of solutions? And the problem is that we need true personalizations. Some vendors have tried to solve the Medicaid subpopulation differences by taking a personalization approach. And even those personalized approaches have failed. So you think to yourself, well, okay, we're supposed to personalize, they personalize, and yet they still failed. What happened? Many in big tech have been left scratching their heads as to why it didn't work. And you've seen big names, the Haven exit, Google Health exit. You've seen folks come in, figure that they could figure it out, and then leave. And everybody's scratching their heads and wondering why. So, if Medicaid populations are unique, why can't we just personalize to them and succeed? Why can't we just match and then deploy? And let me talk you through what the driver of failure has been specifically. So here's the problem. The problem has to do with the way that first-generation digital health solutions approach personalization, which has often been called by them fingerprinting. So I like to say we fingerprint solutions, and yet they fail. What happened? So let me take you inside the standard digital health playbook. Get as much data as you can on as broad a population as you can, build clusters using data science or other kinds of approaches, define personas that are based on those clusters, and then design solutions that are matched to those personas. And then refine the matching algorithms over time, apply a lot of scrutiny, apply a lot of expertise, especially to annotating the data, which is really important when you're doing machine learning. And then it should work, right? And yet you look at the ecosystem, that's what most of the solutions have done, and they haven't really succeeded well in the Medicaid space. The end result of that playbook, which has now been run thousands of times by many companies and really forms the core of how digital health looks at product development, it works when the interpersonal differences dramatically exceed the intrapersonal differences. In other words, if the differences between people are really, really great, but people don't change over time, like fingerprints don't change over time. If people generally remain the same over time, then those solutions work. In other words, if people's engagement levers, think of the user journey, okay, the things that people do over the course of their use of these things, and think of all the places that they can exit ramp off of those. We call those journey exit nodes. If all those journey exit nodes are fairly static, you can address them, close them off. If they're predictable based on initial conditions, you're good to go. You got a digital health solution. People who start it will stick with it. That's not what's happening. What's happening is people who start with digital health solutions in many cases drop out after a few weeks. Why did they do that? And the primary reason is that intrapersonal differences are really great. Think about a habit that you had, a habit that you tried to form. What made you stop? Maybe at one point you wanted a drill sergeant like trainer. Later on, you didn't. It's context dependent. So the key here is that this model for digital health product development is not dynamic. It's not adaptive. And if it does adapt, it adapts very painfully, manually, with a lot of effort. So the adaptation, the dynamic adaptation, is not scalable. Now, AI offers a unique capability to do that, but folks aren't applying that. They're mostly focusing on the differences between people, and that results in a lot of churn. The machine learning models that people are generally using today, they require very heavy supervision, a lot of manual readjustment. I think that's kind of the dirty little secret in AI. And so the entire architecture is really not built for a phenomenon that's endemic to behavior and endemic to habits. And that's that intrapersonal differences exceed interpersonal differences when it comes to habit formation. Let me put it more simply. People drop out. People drop out of these solutions. They stop using it. They leave your user journeys at various exit nodes. You nudge them, they get annoyed. You remind them, they delete your app. You aren't relevant to them anymore. They have life to deal with. Nudging them about taking a blood sugar measurement is not even zero priority for them. It's below zero priority. It's negative priority. They will expend effort to figure out how to delete your solution because it's annoying to them. You lost their trust because you lost relevance to what matters to them. And unfortunately, that is the norm in first generation digital health solutions. So, what's the alternative? Imagine how lives could be transformed if we offered solutions that could actually address in a personalized way our most vulnerable populations. I would say, as you're looking at these solutions, always demo the products, observe how the personalization changes over time, look for experiences inside the solution that indicate things like cultural sensitivity and inclusivity, and in particular, how those solutions adapt over time to really match those intra-member differences. We're seeing a lot of point solution fatigue. Don't come to me. Don't come to me with a solution for just one condition. We don't have members with one condition. That's not the norm. It's mostly overlap. And come to me with solutions where the insights from conditions and overlap can really inform each other. Let's see unified approaches to screening, unified user journeys, unified coaching across the most common conditions that simplifies the user experience, that allows the data to inform other conditions. Right now, if you look at solutions, the norm on sharing data, on sharing intelligence, the norm is they don't do it. Folks won't do it. They say they could do it, but then it ends up being some expensive integration that needs to be built, and one thing leads to another, and IT, department funding challenges. End result is nobody outside the vendor can see what's going inside the data and the intelligence. Certainly nobody at the health plan, and definitely downstream at the provider level, nobody can see anything. So it's all these little black boxes that are separate, these walled gardens of data. Now, on the other hand, if you have solutions that are multi-condition from the jump, they're designed for multi-condition deployment. They were designed for integrated screening and user journeys. They were designed for dynamic populations. They're designed and have demonstrated track records in low-income populations. They have true adaptive approaches to personalization of user journey. They have a clear consumer-driven focus. You can even go buy their solution, the direct-to-consumer versions of their solutions, at Amazon or Walmart or at the Best Buy or even at your grocery store. That's where you can solve the primary challenges. If you built the device, if you built the solutions with broad device kinds of integrations, backwards compatibility to the oldest phones that many of our members we know are using in this space, asynchronous user journeys that work for the lives of the people we serve, that don't require continuous broadband access, there's tremendous opportunity. So I would say that, as you look at this, Medicaid plans really need to hold the solutions accountable for engagement rates rather than taking a population-based pricing approach. Sometimes that can make sense, but often and usually it doesn't make sense because of such wide variation in the use of the solution, such wide variations in engagement. You need granular report. If you're going to pay per engaged member, you need granular reporting on what each member did. What did they actually do? And to be able to see that. And that's really important. That's also not the norm. what changes were noted in the clinical outcome metrics, things like estimated HbA1c and validated pain measurement scales and validated behavioral health instruments and patient-reported outcomes. And then it's also critical not only to ask about ROI, but an ROI that works in Medicaid, considering the member churn and the time horizons that you need to get to value, because those may not exactly work very seamlessly within other solutions and other approaches to ROI. And then I would also ask, how are data and intelligence shared back with the plan, back with the provider? Is it just an app in the EHR store? Is this just an Epic app and that's how you're doing it? Is it that you paid to license on the platform of one of these commercially available interoperability platforms? Because those don't exactly work very seamlessly with health plan care management and analytic platforms either. Sure, you may get the data, but it's in a place, in a format, in a frequency that you can't really use. You can't action on that. And it's very clustered and it's very cumbersome. So I would always ask the solution, what is your native capability? Not something you can build for whatever, $100,000 millions of dollars, in terms of a pipe for us specifically. What's your native capability to normalize data, to exchange those data and intelligence in a way that works for care teams, in a way that works for health plans and providers? Can you put these insights in the time, in the place, in the format, and with the frequency that is important to our care model? Or are you going to disrupt and blow up our care model? And that, by the way, that capability is actually extremely rare. So what I have on the screen here now is a decision matrix. We interviewed, I interviewed some of the chief medical officers, the chief digital of health plans in this space, asking them, what's really important to you when you look at evaluating. And you can see them here. It's really important that folks like the solution, that they use it, that they keep using it, because no matter how good it looks in a study out of Stanford or wherever else, if people won't actually use it, if you can't show your engagement rates, your retention rates, what does that funnel look like? Then I think you should be very skeptical about it. What is your experience specifically in low socioeconomic? What portion of your users today across the platform are low socioeconomic status? You should ask that question. I think that's very important. Can I see the data? We talked about data normalization. We talked about native capabilities in that space versus some aspirational dream that one day we might build a pipe to be able to see what's going on. Now that doesn't work. That doesn't work. Interoperability, data security. Is the risk aligned? I think solutions in this space should basically put all their fees at risk. All the fees should be at risk against clinical outcomes. And if someone won't do that, you got to ask yourself, why not? What is it about? It's kind of like the direct to consumer. Why can't I look at it? Why can't I see the data that's going on? Why can't I buy this myself and use it? Why can't you put all the fees at risk? I think the primary reason for that is people may be skeptical about whether their own solutions will work. And that should also be, I think, a red flag. Operational complexity is huge. In Medicaid plans, we're dealing with all kinds of complex things in regulatory environment, local, highly changeable. How much work are you going to make me do at the plan to access the value that is in your solution? And if I have to add FTE or complexity or deprioritize some other project to do this, it's gonna be really, really hard to gain traction. And then you put all this effort into a pilot and then it doesn't commercialize. And think about how much over the course of the years, just look back at it. Think about how much value was destroyed because solutions were tested and tried that really weren't gonna work. And we expended a lot of effort and time and resources into them, and they never commercially scaled. And then we talked about ROI, and I think ROI is super important here for Medicaid specifically. Operating on thinner numbers here, shorter time horizons, looking at member churn, how quickly you need to get to value, lower cost solutions. I do think that in digital health, most solutions are overpriced. There's either price obscuring, where they're pricing on a population level, or we'll charge you 6 months for each member. That doesn't make sense. It should be per engaged member, per user. It should be platform access. You should access all the conditions. Should put fees at risk. Should be very transparent. Should be very simple and easy to understand, so that there can be some accountability on ROI as well. And I think that's really important. I want to thank you for your attention today. I think we've covered a lot of really complex areas as Medicaid plans seek to evaluate and evolve their digital strategies. Vendors are not going to set your digital strategy for you. They shouldn't. They're going to try to, but you shouldn't allow them to do that. You should set your digital strategy. So look for folks with specific experience in the space, folks who play well in the sandbox with others, where sharing insights and intelligence is the norm, where those are native capabilities with high engagement, with high retention rates, with consumerism, a kind of experience, and with direct experience within the populations that you serve. That does narrow down and winnow down the list of opportunities significantly. And of course, we at Dario would be happy to speak with anybody who wants to learn more about this. You could just shoot an email to bb@dariohealth.com. Thank you.